All right, so a very good evening, everyone. Right, so I hope everyone is doing good, and let us start the discussion of the previous year questions of the medicine questions. So, and I hope everyone is also feeling well about the general medicine because this is one of the very important scoring subject for your exam as well. So I'll try to quickly, revise some of the very important previous year questions which have been asked related to the medicine. All right. Now, so the first question is, yeah. So good evening, everyone. Right. So let us take up the first question. So according to the AHA, the nosocomial infection is said to occur within how much time of the hospital admission? Yes. Yeah, Tahir, good evening, Tahir. Yes, I'm doing well. Thank you very much. Yes, anyone want to make an attempt of this question first? Great. So, to call it as the nosocomial, within 48 within 48 hours of admission of to the hospital, if the individual develops infection, that is called as the nosocomial infection. Now, we have one more important question called, apart from this nosocomial infection, this we call it as nosocomial pneumonia. Whereas another important terminology which is being used is the ventilator associated pneumonia. Now, for ventilator associated pneumonia, the duration is not the same 48 hours. Can anyone tell me what is the duration for ventilator associated pneumonia? Any one of you? All right. So, for ventilator associated pneumonia, after placing the individual on endotracheal tube for nearly around 48 to 72 hours, right? For nearly around 48 to 72 hours. After 48 to 72 hours of placing of the endotracheal tube, if at all if the individual develops pneumonia, then that is called as the ventilator associated pneumonia. Now, what are the, yeah, now can anyone tell me what are the most common organisms that will be causing your nosocomial pneumonia or ventilator associated pneumonia? Any one of you? Most common organism that will be causing your VAP, ventilator associated pneumonia. So one of the most common organism that will be causing ventilator associated pneumonia will be your Pseudomonas, right? So Pseudomonas is a very important organism that is responsible for your ventilator associated pneumonia, right? So now if they have asked you about the nosocomial pneumonias or nosocomial infection, what is that you can anticipate to be asked is about the ventilator associated pneumonia, all right? Now we'll move on to the next question, right? Yeah, I will discuss the important topics list also. I will discuss the important topics list as well, right? First, let me just discuss, the important PYQs. Then followed by that, I will take up the discussion of the important topics list as well, right? Now, so all of the following are the features of the syndrome of inappropriate antidiuretic hormone, except any one of you? Yes, I'm just waiting for your answer. Great. So So what is that you don't see is you will not have decrease the urinary sodium. You will not have decreased urinary sodium. Now what happens in patients with SAADH is there will be increase in the urinary sodium. That is very important point. Now let me just tell you the complete workup of the SAADH, which is very important area where the questions can be tested. Now in patients with SAADH, the serum sodium it decreases, whereas the urine sodium, it increases, right? And the next important is about the osmolality. Now, if you take the serum osmolality, that will be decreased, and urine osmolality, that will be increased in patients with the SAADH. Now, what is the investigation of choice in patients with SAADH? Investigation of choice in patients with the SAADH will be water loading test. Okay, so water loading test, that is the investigation of choice in patients with the SAADH. And what is the first line treatment in patients with SAADH? The first line treatment in patients with the SAADH is you need to restrict the water intake. So water restriction is the first line treatment in SAADH. And at the same time, if the question is asked like what is the drug of choice? Drug of choice in patients with SAADH will be Vaptans. Right? Drug of choice will be Vaptans. Okay. So that is the correct answer. Now, yes. So the question asked is except. Do you have hyponatremia? The answer is B. Right? Do you have hyponatremia? Definitely yes. Ascites is absent? Yes. You don't have ascites in patients with SAADH. And do you have pedal edema? There is no pedal edema. Right? What could be the reason? Because there will be activation of compensatory mechanisms that will send the water out. That is the reason why you don't have, usually in SAADH, what will happen? There is increased water reabsorption. That happens only initially. But once the compensatory mechanisms begin, that excess water which is being reabsorbed gets excreted out. So remember in SAADH, you don't have ascites and you don't have the pedal edema also. Right? Very, very important point. Okay. Now, we move on to that. And what exactly is opposite to your SAADH? Opposite to your SAADH is your diabetes insipidus, right? In diabetes insipidus, we have two forms, central diabetes insipidus and as well as nephrogenic diabetes insipidus. And in diabetes insipidus, the investigation of choice will be water deprivation test. And right, it is the water deprivation test. And in case of central diabetes insipidus, the drug of choice is desmopressin, whereas in nephrogenic diabetes insipidus, the drug of choice is thiazides. Right? In nephrogenic diabetes insipidus, the drug of choice is thiazides. Okay. So this is the exact opposite to that of your the SAADH. That is nothing but your diabetes insipidus. Now, if you want to take a comparison between diabetes insipidus and as well as the SAADH, right? If you take the quick comparison, you take the serum osmolality. Serum osmolality in patients with diabetes insipidus, it will be increased, and whereas in SAADH, it will be decreased. And you take urine osmolality in patients with diabetes insipidus, that will be decreased in diabetes insipidus, whereas increased in case of SAADH. And if you take the serum sodium in diabetes insipidus, it is increased, whereas in SAADH, it will be decreased. And if you take the urine sodium, that will be on the lesser side in diabetes insipidus, whereas it is increased in case of the SAADH, right? And the investigation of choice already I have discussed. Investigation of choice in diabetes insipidus will be your water deprivation test, whereas in SAADH it is water loading test, right? So these are the important differences that you need to remember between your diabetes insipidus and as well as the SAADH. Done? Now, moving on to the next question. Right. So mother is tested for surface antigen positive and gives birth to a full-term baby. What is the correct treatment protocol to prevent transmission of the hepatitis B infection? Yeah. Anyone want to make an attempt of this question? Yes. Quickly, anyone want to answer this? I'm waiting for your answers. Right, great. Right. So the correct answer here is you need to give the hepatitis B immunoglobulin to the baby. Right? You need to give hepatitis B immunoglobulin to the baby. And this hepatitis B immunoglobulin should be given as soon as possible, right? Preferably within 12 hours. And what will be the route of administration? The route of administration of your hepatitis B immunoglobulin will be the intramuscular route of administration, right? And after giving this hepatitis B immunoglobulin, you need to vaccinate, right? You need to vaccinate the individual, right? You need to vaccinate the baby. So that is when the transmission can be reduced. Otherwise, the risk of transmission will be almost 90% in case of vertical transmission. And risk of transmission is maximum during the labor. The risk of transmission is maximum during the labor, right? So this is about your, like, what is that you need to do to the baby, right? Okay. Now, one another quick question. For example, an intern is doing or taking a blood sample and he had a needle prick. Yeah. Now please tell me, how will you approach this individual? When the intern had a needle prick, and how will you approach this individual? Yeah, please answer this. Right. So, if at all, right, if an intern had received a needle prick, or anyone, in fact, it is not just only the intern, right? It is just not only the intern. Okay, just 1 minute. Many of you are asking with the important topics. So, do you want me to tell the important topics first? Right. So, okay, I'll complete that question and then I'll come to the important topics, right? I'll complete that question and then I'll come to this important topic story, okay? Just give me 1 minute, okay? 1 minute. Right. So, yeah, let me just finish this first. Yeah. Now, so in the intern, what is that you should ask for? Whether the individual is vaccinated or not, right? If suppose, if you suppose, if the individual is not vaccinated, if the individual is not vaccinated, then what is that you should make the individual to get it done first is you should give hepatitis B immunoglobulin as soon as possible. You should give hepatitis B immunoglobulin as soon as possible, right? And then followed by that, you should revaccinate, I mean, you should vaccinate the individual. Vaccination should be given. So this is the scenario where the individual had acquired a needle prick from hepatitis B positive patient, right? But he is not vaccinated. That is the first scenario. The second scenario is the individual is vaccinated. If suppose in such scenario, what is that you should do is you should check for the anti-HBs titer. If the individual is vaccinated, you should check for anti-HBs titer. Now, in the anti-HBs titer, if it is more than 10 units, if the anti-HBs titer is more than 10 units, then definitely you need to just follow up this individual. They don't require any further vaccination or they don't require any hepatitis B immunoglobulin. But for suppose, if the anti-HBs titer of the individual who got the needle prick but vaccinated is less than 10 units, then in such case, what you should advise the individual is the individual has to take hepatitis B immunoglobulin 2 doses 1 month apart. Right? The individual has to take two doses 1 month apart. So that is how you have to give the vaccination to the individual if the titer is less than 10 units. Okay, so this is how you need to approach the post-exposure prophylaxis in case of the hepatitis B, which is a very important area for your questions. Right now, as many of you are interested in the important topics, right? So let me just zoom this. 1 minute. Yeah. So these are the must know topics for your MDS, either NEET or the INI-CET MDS. These are must to be known. What are those? Number one, in cardiology, please go through your coronary artery disease, that is the acute coronary syndrome, wherein in the acute coronary syndrome, you have to know about the STEMI, NSTEMI, unstable angina, and as well as acute management of the acute coronary syndrome, right? Then you also need to be aware of complications, bradyarrhythmias, tachyarrhythmias, mitral regurgitations, then ventricular septal defect, all that you need to know. Second important topic in the cardiology, which you should not miss before going to your exams, is your heart failure. What are the drugs for heart failure? What is acute and chronic? And what exactly is your cardiogenic shock? Then, third important topic in the cardiology that you should never miss before going to your exam is arrhythmias. And in arrhythmias, what is the topic that you should read definitely is atrial fibrillation. Atrial fibrillation is a hot favorite topic for the examiners, mainly the treatment aspect. Or you need to know about this scoring system, your CHA2 DS2 VAS scoring system, very important area for the exams, right? Now, next, valvular diseases, you need not know in detail, at least basics. The auscultation in valvular heart diseases, you need to know definitely. Then followed by that, infective endocarditis. In the infective endocarditis, what is that you need to know? The dental prophylaxis. Which group of individuals will require dental prophylaxis? I mean, which group of individual will require infective endocarditis prophylaxis before going to the dental procedure? What is the antibiotics that you should give? When is the antibiotic that you should give? That you need to know in case of infective endocarditis. So in cardiology, acute coronary syndrome, heart failure, arrhythmias, valvular heart diseases, basics, then infective endocarditis you should know. Done? Now, coming to the respiratory system. What are the important topics that you should revise before going to your exam, or the one you should never miss in the respiratory system? So, in the respiratory system, your pneumonia, community acquired pneumonia, hospital acquired pneumonia, and as well as the aspiration pneumonia. Now, in the pneumonia part, what are the questions that they will be expecting from you is very simple. They will give you one clinical scenario of a patient of pneumonia. What is the next step in the management is what they will be asking you. So how is that you will be able to make out the next step in the management? That is by calculating the curve 65 score. So you need to calculate the curve 65 score in a given patient, then you will be able to decide what is the next step in the management. The next important is common organisms and antibiotics. But curve 65, you should never miss at all. Very important. Done. Next is the COPD and as well as the bronchial asthma. Two of these, you should know the criteria and as well as management. And the other important is the pulmonary embolism. Because COPD and bronchial asthma, why it is very important is whenever you are doing a dental procedure on a dental chair, the individual had an acute asthma attack. How is that you will be able to handle that, right? Or what is the immediate management that you will be doing? Those are the type of questions. Next is pulmonary embolism. Next, you need to know the types of heart failure: type 1, type 2, type 3, and type 4 heart failure. Then followed by that, in the pulmonary embolism, mainly you need to know what is the investigation of choice, that is your CT pulmonary angiography, when to give anticoagulant, when to do thrombolysis, when to give anticoagulant, when to do thrombolysis. These are the topics important in respiratory: pneumonia, asthma, COPD, pulmonary embolism, respiratory failure, right? So don't go to the exam without revising these topics or without reading these topics. Done. So that is about your the cardiology and as well as the respiratory topics. Now, followed by that, the gastroenterology and as well as the hepatology topics, right? Now, in the gastroenterology and hepatology, mainly if you take the liver diseases, that is cirrhosis of liver, right? You should know what is compensated cirrhosis, what is decompensated cirrhosis. In the decompensated, what are the complications and what is the drug of choice for these complications? For ascites, what is the treatment? Variceal bleed, drug of choice and first line treatment. Then encephalopathy, the drug of choice. So cirrhosis and its complications definitely to be read. Now, without viral hepatitis, don't expect a paper at all. And that too in the viral hepatitis, the hepatitis B, very, very important. Either modes of transmission or in the modes of transmission, mainly the needle prick questions, right? The one what I have said you. Or vertical transmission, that is from pregnancy to the baby. Next important is the serology in the viral hepatitis, that is mainly hepatitis B. When will the surface antigen appear? If it is there, what does it indicate? When do you call acute? When do you call chronic? When do you call carrier? When do you call vaccinated? When do you call the remote infection? In gap period, what will be the serology that will be positive? What is window period? So serology very important, mainly in hepatitis B. Then followed by that treatment in hepatitis B. What should be the HBV DNA levels to start the treatment? What is the cutoff? So in viral hepatitis, please concentrate on hepatitis B. Then followed by that, the acute abdomen basics. So in the acute abdomen, mainly pancreatitis and intestinal perforation. Actually, you will be learning the same in surgery as well, but even from medicine point of view also it is important. Now, very important is jaundice. Pre-hepatic jaundice, hepatic jaundice, post-hepatic jaundice, right? What will be the pattern of direct bilirubin, indirect bilirubin? Pattern of AST, ALT, pattern of alkaline phosphatase and GGT, right? So in these three, you should know all these patterns, right? Next, then so this is about in gastroenterology and as well as hepatology. Cirrhosis of liver and its complication, viral hepatitis, jaundice and its patterns. These three are very important areas in gastroenterology and hepatology. Now, the next is the nephrology. Now, in the nephrology, often tested area is acute kidney injury. So, in the acute kidney injury, the etiology, pre-renal, intrinsic renal, post-renal. How will you differentiate one from the other? And how do you manage acute kidney injury? What is the indications for dialysis in patients with acute kidney injury? This is very, very important in AKI. Next, differences between nephrotic syndrome and nephritic syndrome. And what are the etiologies that will be causing nephrotic and what are the etiologies that will be causing nephritic? Very, very important area for the questions, right? Then followed by that, electrolyte abnormalities. Which electrolyte abnormalities are important to be asked? Sodium, potassium abnormalities, acid-base disorders, one question to pakka. Acid-base imbalances, one question pakka, 100%. That important is your acid-base disorders. Then followed by that, chronic kidney disease. So in the chronic kidney disease, like right. So in the chronic kidney disease, like you need to know the staging. Stage 1, stage 2, stage 3, stage 4 and stage 5, right? Then what are the indications for dialysis? So this is in the nephrology. Done. Next. So in the nephrology, acute kidney injury, chronic kidney disease, nephrotic syndrome, nephritic syndrome. Okay. Next. Then followed by that in the endocrinology. Endocrinology, diabetes, thyroid, adrenal disorders. In the adrenal disorders, what are the areas that are expected? That is Addison's, Cushing's, pheochromocytoma. Then calcium related disorders. Calcium related disorders will be your hypo and as well as the hyperthyroidism. So this is about your endocrinology. Without diabetes, you will not have the question paper, right? Mark it from me. Then coming to the neurology. So in the neurology, stroke, meningitis, seizures, and as well as the neurological emergencies. And what are these neurological emergencies? That is your Guillain-Barré syndrome, then myasthenic crisis, and acute confusional states. So these are the neurological disorders that you should remember: stroke, meningitis, seizures. These three are to pakka. Meningitis high scoring. Next, coming to the infectious diseases. What is that we should definitely revise, because we have many infections, sir? So what is that has to be revised? In the infections, sepsis and septic shock criteria, antibiotic timing, and what is that sepsis bundles. Then followed by that, what are the newer guidelines for tuberculosis? What are the newer guidelines for the HIV treatment? And some tropical infections like dengue and malaria, very important. So these are the things in infections: sepsis, tuberculosis, HIV, dengue, and as well as malaria, right? Then followed by that, the hematology. Hematology, definitely you'll be concentrating in your patho as well, but from the medicine point of view, what is that you need to know, like, is the coagulopathies, right? Mainly you need to make out the dental relevance, that is your DIC, vitamin K deficiency, warfarin, or the basics of newer oral anti-epileptic, newer oral anticoagulants, right? Next, leukemias and lymphoma basics. So these are the important area in hematology. Then followed by that, rheumatology and as well as immunology. In rheumat, the areas which are important is rheumatoid arthritis and SLE. Then followed by that, vasculitis. These three areas are very important: SLE, rheumatoid arthritis, and vasculitis. And in the vasculitis, mainly you need to know the large vessel vasculitis and their dental correlates. Okay. Then followed by that, the next one is the emergency medicine and as well as the critical care. Right. So in the emergency medicine and critical care, ACLS guidelines are very importantly asked. Indications of defibrillation. What are the types of shock? Right. And coming to the poisoning and as well as the common antidotes. Poisoning and as well as common antidotes. Okay. So these are the areas. I'll be posting this entire PDF on the Telegram channel also. So without revising these topics, right, it becomes very difficult for you to attempt the medicine questions. So please do revise these topics before you go to your exams, which will definitely give you an extra edge in your preparation. Because medicine being so voluminous, it becomes very difficult to us, like what to revise, what not to revise. These topics you revise just before going to your exams, right? So I hope this point is clear, because like like what are the important topics that has to be read is what some of you are asking in the group. Okay, now we move on to the PYQs. Yeah, answer this. Right. So if you see the next question, we have a patient with fever, cough, and the weight loss. Show It shows a chest X-ray, a cavity defect with a positive MAN2 test. The patient is under treatment now and complains of burning and as well as tingling sensations in the fingers and legs. What is the likely cause for it? Right? What is the likely cause for it? Anyone want to make an attempt of this? Right. So the likely cause here is, in case of tuberculosis, what do we start as a first line? We start the isoniazid, right? Now, what is the problem with the isoniazid? That is associated with pyridoxine deficiency. And that is the reason why the individual is developing the symptoms of the neuropathy. What will be that? Burning and as well as tingling sensation in the fingers and as well as legs. Okay. And there is one more important molecule. It also causes pyridoxine deficiency. That is your D-penicillamine. Now, can anyone tell me Where do you give this D-penicillamine? Which disorder we give D-penicillamine? And at the same time, whenever you're giving D-penicillamine, you should also supplement the patient with pyridoxine. Any one of you? Which conditions you give D-penicillamine? I'm waiting for your answers. Great. So D-penicillamine, it's a chelating agent, right? And it's a chelating agent for what? It's a chelating agent for copper. So what is the disorder where we have the excess copper in our body? That is Wilson's, right? So that is when. So D-penicillamine also causes the pyridoxine deficiency, right? Yeah. So very good, Lakshita, Hemalata, and as well as Adirabur, and the remaining all whoever are answering this. So Wilson's, whenever you are giving D-penicillamine, you need to give the pyridoxine. The next question. And okay, before going on to the next question, tell me what are the new molecules for tuberculosis? Because as this is actually the question of tuberculosis, you should not miss without discussing what are the new molecules which have come up for tuberculosis. Any one of you? What are the new molecules for tuberculosis? So the new molecules that have come up for the treatment of tuberculosis is we have pretomanid, then bedaquiline, right? Pretomanid and as well as the bedaquiline. So these are the new molecules which have come up for the treatment of the tuberculosis, right? Okay. We move on to the next one, right? So after radiation for squamous cell carcinoma in head and as well as neck, a patient develops dryness of eyes, and for which the doctor prescribes eye drops to correct the same. Patient can develop which of the following later on? Anyone? Patient can develop which of the following later on? Problem in focusing the nearby objects, problem in vision in dim light, increased intraocular pressure. Great. So what is that this individual who is on radiotherapy can develop is two things. One, he will develop the problem in vision in the dim light. That is number one. And there will also be increase in the intraocular pressure. So the answer is B, right? So problem in vision in dim light. The second one is increase in the intraocular pressure. Now, because what could be the reason? The radiotherapy, it will cause cataract, right? Radiotherapy to the neck and head, it can cause the development of cataract, or there can be development of glaucoma, and they are the one which will be responsible for. So why there is intraocular pressure, raised intraocular pressure? Because of the development of glaucoma as the complication of radiotherapy to the neck and as well as head. So that is the reason why there will be increased intraocular pressure. Okay, right. So the answer is both 2 and as well as 3. Yeah. So a man reported with edema of leg. All of the following conditions can be a reason except. All of the following conditions can be the reason except. So in which condition you will not have edema? Right. So edema in the leg, it could be due to two reasons. What are the two reasons? One, there will be either decrease in the oncotic pressure within the vessel, right? That can cause edema. Second, due to increase in hydrostatic pressure within the vessels, that will be causing the edema, right? Now, you take protein malabsorption. So, in case of protein malabsorption, very good. All of you are answering it correctly. B. So in protein malabsorption, what will happen to the protein levels? That will be reduced. So this will decrease the oncotic pressure within the vessel. Right. So once there is decrease in the oncotic pressure, there will be extramuscular accumulation of the fluid resulting in edema. Now, in these two conditions, you will have the fluid overload. Right? You will have fluid overload. Understood? Now, this fluid overload will cause increase in hydrostatic pressure. And once there is increase in hydrostatic pressure, the fluid from vascular compartment will enter into the extravascular compartment that will result in the edema. Whereas in irritable bowel syndrome, this is completely a functional disorder. The irritable bowel syndrome is completely a functional disorder. So in case of irritable bowel syndrome, you don't have any edema. So wherever there is fluid overload, you will have the presence of edema. Now, what is another condition where you can have the fluid overload and as well as decrease in oncotic pressure? Any one of you? Which is the condition where there is fluid overload and along with that there is also decrease in oncotic pressure? Any one of you? In which condition you will have this? Yes. Right. So the fluid overload and decrease in the oncotic pressure, it is observed in cirrhosis of liver. Right? It is observed in the cirrhosis of liver. In cirrhosis of liver, you have fluid overload and at the same time decrease in oncotic pressure due to hypoproteinemia. Due to hypoproteinemia, right? Yeah. And right, great. So it is not just only cirrhosis of liver, even in case of nephrotic syndrome. But in case of nephrotic syndrome, it is actually decrease in oncotic pressure first. Only decrease in oncotic pressure will be there in nephrotic initially. But if nephrotic progresses to chronic kidney disease, that is when there will also be the fluid overload in the individual. That is when there will be fluid overload in the individual. Okay. So this is about the conditions where you will have the edema in the leg. So irritable bowel syndrome, you don't have hypoproteinemia and you don't have the fluid overload also. That is the reason why you don't have any edema in patients with the irritable bowel syndrome. Done? So that is a question. Now, can anyone tell me what are the drugs which can cause pedal edema? Very commonly used drugs. Drugs which can cause pedal edema. Anyone? Drugs causing pedal edema. And one of the very commonly used drug, and that too it's an antihypertensive. I have given you a clue also now. It's an antihypertensive. Which is that antihypertensive? That is your amlodipine. Right? So amlodipine is the calcium channel blocker which can cause pedal edema. So if at all if there is development of pedal edema with amlodipine, then what will you do? You need to stop this drug. Then the alternative that you need to use is cilnidipine. Cilnidipine is not associated with the development of the pedal edema, right? Very, very important. Yeah, very good, Lakshita and as well as Sambit, right? So it is your calcium channel blocker. Done. Next. Yeah. So patient reported colitis in the lower abdomen or lower bowel. There was an increase in Clostridium difficile. What will be the cause for the same? Now, can anyone tell me what is the diagnosis first of all in this question? What do you think is the diagnosis in this question? Any one of you? Yeah, very good, Afreen. You have answered it correctly. But can you tell me what could be the diagnosis of this clinical scenario? It is your pseudomembranous colitis, right? It is your pseudomembranous colitis. And pseudomembranous colitis is due to what? The pseudomembranous colitis is due to the antibiotic therapy. It is your antibiotic therapy. Okay. Now, which antibiotic therapy is like most common? One is, I'm sorry. So one is the clindamycin, and the other molecule is your cephalosporins, right? Clindamycin and as well as cephalosporins, right? Now, the point is, how do you treat these pseudomembranous colitis? In pseudomembranous colitis, what happens? The organism that will overgrow is the Clostridium difficile. So, what is the drug of choice here? The drug of choice here is you need to give fidaxomicin, right? Fidaxomicin, or mainly we just give this important molecule fidaxomicin. Done. Right. So this is about your pseudomembranous colitis. So presence of Clostridium difficile tells that it is a development of pseudomembranous colitis. It is mainly due to the prolonged antibiotic therapy, mainly your clindamycin and as well as the cephalosporins. Okay. Next. Yeah. While extracting the tooth in an AIDS patient, dentists get the needle stick injury. The treatment option for this for dentist is treatment option for dentist is anyone? Right. So, first point, whenever the individual has acquired the needle prick from the HIV infected individual, do you require post exposure prophylaxis or not? Definitely, the answer is yes. Definitely, the answer is yes. Understood. Now, whenever, when should you give this post exposure prophylaxis? Preferably, you have to give within 2 hours, right? Preferably within 2 hours, you have to give, and maximum is up to 72 hours, right? Maximum is up to 72 hours. Okay, so that means within 72 hours, you should definitely give post exposure prophylaxis. And if you try to give after 72 hours, there will be no use at all regarding the post exposure prophylaxis. Now the question comes, what drugs have to be given? So you have to give among the options which has been given to you, like zidovudin plus lamivudin should be given immediately. But is that the regimen of choice? That is not exactly the regimen of choice for post-exposure prophylaxis. We need to give two NRTIs, right? Two NRTIs, and along with NRTI, two NRTIs, you need to add one, right? You need to add one integrase inhibitors. Now, what is the example of the integrase inhibitor that we add usually is we add dolutegravir, right? And yeah, dolutegravir. And next important is the two NRTIs. What are these two preferable NRTIs for post-exposure prophylaxis? One is your tenofovir, which is called TDF, right? And along with that, we have FTC. Now, what is this FTC? That is your emtricitabine. So these three are the molecules that have to be given: tenofovir, emtricitabine, then dolutegravir has to be given. For how long you need to give? This regimen should be given for nearly around 28 weeks. This regimen should be given for nearly around 28 weeks. Definitely, we have some other alternative regimen also, but the preferable regimen is this, right? Where you need to give tenofovir, emtricitabine, and as well as dolutegravir. That has to be given preferably within 2 hours, right? Or you can start, the best possible is within at least 72 hours. Okay, right. Next to the post-exposure prophylaxis. Yeah. While doing pulpotomy in a female, the patient suffers from generalized tonic-clonic seizures. Which of these should not be done? Check epilepsy cards, records first. Use valproic acid immediately. Then protect from the sharp object. Turn on to one side. So, what is that should not be done? I mean, what is that you consider not very important in this question? Anyone? Turn on the side is very, very important. You should definitely turn on the side. Why? Mainly to prevent, right? Mainly to prevent the aspiration, right? Mainly to prevent aspiration. Definitely, you need to turn on to one side, right? Very good book and life of OG and all those whoever are answering now. So that is checking of your epilepsy records first is not important. The individual is having a GDCS in front of you. Try to give an immediate anti-epileptic drug, right? So for GDCS, what is the drug of choice? That is valproic acid. So you can give valproic acid immediately, right? And at the same time, the individual, you should also protect the individual from sharp instruments which are present in and around the dental chair. Okay. Now, very important is drug of choice. Okay. Can anyone tell me what is the drug of choice for your status epilepticus? Drug of choice for status epilepticus. Any one of you? Right. So, drug of choice for status epilepticus, that is lorazepam, right? And drug of choice for GTCS will be valproic acid. Okay. And drug of choice for focal epilepsy, right? That will be your carbamazepine. Carbamazepine. That is a drug of choice, right? Then coming to the drug of choice for atonic seizures and drug of choice for myoclonic epilepsy, okay, and drug of choice for juvenile myoclonic epilepsy, okay, drug of choice for atonic seizures, myoclonic epilepsy, and juvenile myoclonic epilepsy. So in all these conditions, valproic acid is considered as the drug of choice, right? Valproic acid is considered as drug of choice. Then, if the question is asked, what is the drug of choice for infantile spasm? Can anyone answer this? Drug of choice for infantile spasms. So, the drug of choice for the infantile spasm will be ACTH. Drug of choice will be ACTH, which is very, very important. Done. And what is the drug of choice for infantile spasms plus tuberous sclerosis, right? What is the drug of choice for infantile spasm plus tuberous sclerosis there? Then the answer is vigabatrin, right? Vigabatrin. That is a drug of choice. Okay. So you need to know the drug of choice for various types of epilepsy, and at the same time, you also need to know the importance of what to do first in a patient with the epilepsy having in a dental chair, right? So this is about your short note on the epilepsy. And I just want to tell you one important point here. The e-Gurukul, like DBMCI, MDS vertical, has started the Revision Pro series. And in this Revision Pro series, like what are all available? Number one, you have less than 120-hour revision videos are there in this Revision Pro videos. Number two, there is completely a latest solved papers of the INI-CET May and as well as NEET MDS 2025. And you have a complete access to the test and discussion. And you will also get nearly around last 10 years PYQs with explanation with this Revision Pro series. And not only that, you can also test yourself by giving GTs, subject-wise test, right? And a special focus is definitely given on the image-based questions, okay? And not only that, by the subject faculties, you will also be having a daily mentorship by the expert faculty, right? So these are the things that they are providing in the Revision Pro series of the DBMCI MDS. So whoever are interested, right, you can just take this particular subscription. Yeah. So we have one doubt. Status epilepticus, remember, drug of choice is lorazepam. It is not diazepam. Lorazepam is the drug of choice. Okay. Right. And uh, asking IV diazepam and valproic acid. These are specially the drug of choice for. Okay. So valproic acid, I said, right? Valproic acid, it is the drug of choice for GTCS, and valproic acid, it is also the drug of choice for atonic epilepsy, myoclonic epilepsy, and as well as the juvenile myoclonic epilepsy. So for all these, your valproic acid is the drug of choice. Done. Now, what is the next thing that you are asking? Diazepam. So you take this diazepam. Okay. So you take this diazepam. Diazepam, it is used in case of your status epilepticus. It is used in case of your status epilepticus if the patient is not having adequate response to lorazepam. Lorazepam is the drug of choice actually. If the patient does not respond to lorazepam adequately, that is when you need to give the diazepam, right? So this is about the story related to the. I take up one question now. Yeah, Priya Agarwal is asking about the coarctation of aorta. Okay. This coarctation of aorta, what are the important points that you need to remember? Let me tell you. So, this is your four-chambered heart, right? And this will be your ascending aorta, arch, and then descending aorta. And from this point, you have the left subclavian artery. Now, where will be the site of coarctation most commonly? Right? Yes, Priya Agarwal. This is the explanation for your question. So, if the most common site for coarctation will be, this is the site. That is, distal to the left subclavian artery is the most common site for coarctation. And if at all, if the coarctation is present distal to left subclavian artery, then what is that you will have? You will have what is called a radiofemoral delay. Right? You will have what is called a radiofemoral delay. Very important. If the coarctation is present distal to the left subclavian artery, right? Now, the next point is, if suppose, if suppose, if the coarctation is present, okay, so if the coarctation is present proximal to, okay, so if the coarctation is present proximal to the left subclavian artery, then in this case you will not have radiofemoral delay. What is that? You'll have left subclavian artery will get the lesser blood supply, right subclavian artery will get a good blood supply. So this will result in radial delay. Right? So you'll have what is called radial delay. So this is what is your, if the coarctation is present proximal to the left subclavian artery. Then what is the murmur that you will have if there is a coarctation? The murmur that you need to give is, or you'll have is, a continuous murmur will be there. Right? Continuous murmur will be there in case of the coarctation of aorta. Right? And yeah, these are some of the important points related to your coarctation of aorta. Yeah, Priya Agarwal, did you understand this point? Hmm? Right. So I have one more session, that is the doubt clearing session, or the topics what you can ask, and I will be able to tell you that in that particular session. Okay. This session I'll just wind up right now. So in that particular session of the doubt clearing sessions, right? I am not sure about the date, but there is one more session wherein I will be clearing all your doubts, whatever you have related to medicine in that particular session. Okay. So with this, I just wind up this particular session and go through all your PYQs very importantly, and very important point related to your exam. At any point of your preparation, don't be demotivated. It always takes certain time for you to get good marks in your GTs, right? So we have seen many students where they were not doing good in GTs, but final exam they have done extremely well. So expect always the best from you, believe in you, trust yourself, don't lose confidence at any point of time. Self confidence is very, very important in your preparation, right? So that's the reason why just trust the process, and it is always the consistency which is very, very important. Consistency will beat the intelligence. So be consistent rather than being intelligent. Be consistent, definitely you will be able to crack the exam. And whatever the GTs that you are giving, or whatever the exams that you are giving, even though you get the less marks, you should understand one point, that the exams, they don't test your knowledge. The exams, they test how resistant you are in giving up the exam. Right? The exams, they test you how resistant you are in giving up the exams, or in giving up your preparation. That is what the exams will test you, right? So with this, I wind up this particular session, and I wish you all the very best. You will definitely come out of the examination hall with the flying colors, right? So thank you very much. I'll wind up this session.